Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 195 of our Pharmacotherapy MCQ series, which majors in cardiology. And the first question reads, WCP, a 65-year-old male patient has just been admitted to your general medical ward due to an exacerbation of his heart failure. He has a past medical history significant for severe renal insufficiency, hypertension and dyslipidemia. His labs include a current creatinine clearance of 20 ml per minute. His other basic labs are within normal limits. So my question to you is, which of the following would be the most appropriate regimen for preventing venous thromboembolism (VTE) in WCP's clinical scenario? Would it be A. enoxaparin 30 mg subcutaneously once daily, or B. rivaroxaban 10 mg orally once daily, or C. fondaparinux 2.5 mg subcutaneously once daily, or would it be D. warfarin 5 mg orally once daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. enoxaparin 30 mg subcutaneously once daily. This is an acute medically ill patient requiring VTE prophylaxis. Warfarin has never been evaluated in this setting and would not likely be effective because of the lag time in achieving therapeutic anticoagulation. Therefore, answer D is incorrect. Although fondaparinux has been evaluated and is effective in these patients, answer C is incorrect because fondaparinux is contraindicated in patients with a creatinine clearance of less than 30 ml per minute. Rivaroxaban has only been evaluated for extended prophylaxis in acute medically ill patients, and patients with a creatinine clearance of less than 30 ml per minute were excluded from the trial. Therefore, answer B is incorrect. Answer A is correct because enoxaparin has been evaluated as safe and effective VTE prophylaxis in acute medically ill patients, and the dose of 30 mg once daily is correct for patients with severe renal insufficiency. Please advance to the next question. And the next question reads, which one of the statements listed below is the most accurate Bazard-corrected QT interval with respect to the electrocardiogram (ECG) strip shown below? Is it A. 520 milliseconds, or B. 437 milliseconds, or C. 414 milliseconds, or is it D. 396 milliseconds? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. 396 milliseconds. measuring from the Q wave until the end of the T wave. The uncorrected QT interval is 0.52 seconds. The RR interval is 1.72 seconds. Using the Bazet formula, which is 0.52 divided by the square root of 1.72, yields a corrected QT interval of 0.396 seconds, or 396 milliseconds. That makes answer D correct, and answers A to C incorrect. Please proceed to the next question. And the next question reads, GNR is a 69-year-old female patient whose height is 65 inches, and weighs 72 kg. She presents to your cardiac clinic. Her chief complaint is paroxysmal atrial fibrillation. She has a past medical history significant for hypertension, dyslipidemia, and drug addiction. Her pertinent labs include a serum creatinine of 0.8 mg per deciliter. Her current medications include lisinopril 20 mg orally once daily, amlodipine 10 mg orally once daily, metoprolol tartrate 100 mg orally twice daily, methadone 100 mg orally once daily, and warfarin 5 mg orally once daily. She has an international normalized ratio of 2.2. She claims adherence to all of her medications. Her pertinent vitals include a blood pressure of 130 systolic and 80 diastolic, and a heart rate of 68 beats per minute. She is in sinus rhythm, but during atrial fibrillation episodes, it is 115 to 120 beats per minute. A recent echocardiogram reveals normal left ventricular function, left ventricular ejection fraction 60%, and no left ventricular hypertrophy. Regarding her chief complaint, she continues to have palpitations and dizziness episodes about 2 or 3 times weekly, which last around 5 to 6 hours. So my question to you is, which of the following would be the most appropriate therapy for GNR at this time? Would it be A. sotalol 80 mg orally twice daily, or B. propafenone extended release 225 mg orally twice daily, or C. dofetilide 500 mcg orally twice daily, or would it be D. amiodarone 200 mg orally once daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. propafenone extended release 225 mg orally twice daily. This patient's paroxysmal atrial fibrillation remains symptomatic, with resting heart rates during atrial fibrillation of 115 to 120 beats per minute, despite optimal attempts at ventricular rate control, maximum dose metoprolol. Therefore, she is a candidate for drug therapy to maintain sinus rhythm or reduce the frequency of atrial fibrillation paroxysms. Amiodarone is not a first-line agent for patients without structural heart disease, rather, it is reserved for patients who do not respond to other therapies. That makes answer D incorrect. Because this patient does not have structural heart disease, dofetilide, dronedarone, flecainide, propafenone, and sotalol are all options. However, dofetilide and sotalol are best avoided in a patient taking methadone because of the potential for additive effects on the QTc interval and possible QTc interval prolongation and torsade de poor. That makes answers C and A incorrect. Although propafenone may prolong the QTc interval in some patients, it is in the credible meds conditional category and is less likely to prolong the QTc interval than dofetilide or sotalol. Therefore, propafenone is preferred for this patient. That makes answer B correct. Please progress to the next question. And the next question reads, KJH, a 66-year-old male patient whose height is 71 inches, and who weighs 83 kilograms presents to your cardiology clinic with paroxysmal atrial fibrillation. He has a past medical history significant for hypertension. His current medications include lisinopril 20 mg orally once daily, and metoprolol succinate 200 mg orally once daily. His calculated creatinine clearance, CRCL, is 70 ml per minute. The cardiologist decides to initiate dofetilide to reduce the frequency of his still symptomatic episodes of AF. KJH is admitted to your CCU, and after determination of his pre-dofetilide corrected QT, that is QTC interval, which is 415 milliseconds, dofetilide 500 mcg orally twice daily is initiated. 3 hours after his first dose of dofetilide, an ECG reveals a QTC interval of 495 milliseconds. So my question to you is, which of the following would be the most appropriate action in this clinical scenario? Would it be A. Maintain the dofetilide dose at 500 micrograms orally twice daily, measure another QTC interval after his second dose, or B. Discontinue dofetilide, or C. Decrease the dofetilide dose to 250 micrograms orally once daily, or would it be D. Decrease the dofetilide dose to 250 micrograms orally twice daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Decrease the dofetilide dose to 250 micrograms orally twice daily. According to the U.S. Food and Drug Administration approved labeling for dofetilide, if the QTC interval increases by more than 15% or to greater than 500 milliseconds within 2 to 3 hours after the first dose of dofetilide, the dose should be reduced by 50%, which in this patient would be from 500 micrograms twice daily to 250 micrograms twice daily. This patient's QTC interval, though not greater than 500 milliseconds, increased by 19%, from 415 milliseconds to 495 milliseconds. Therefore, answer D is correct, and answers C and A are incorrect. Dofetilide should not be discontinued unless, at any time after the second dose, the QTC interval prolongs to greater than 500 milliseconds. That makes answer B incorrect. Please proceed to the next question. And the next question reads, MCV, is a 36-year-old female patient who presents to your accident and emergency department. She has a chief complaint of palpitations, dizziness, and lightheadedness. Regarding her past medical history, she has no history of CVD. Her current medications include occasional loratadine 10 mg for allergies. Her ECG reveals supraventricular tachycardia, abbreviated as SVT, with no evidence of pre-excitation. Her pertinent vitals include a blood pressure in the accident and emergency department of 98 systolic and 78 diastolic, and a heart rate of 138 beats per minute. Neither vagal maneuvers nor adenosine is effective for terminating her arrhythmia. So my question to you is, which of the following would be the most appropriate treatment for MCV now? Would it be A. Diltiazem 0.25 mg per kilogram IV loading dose, followed by a 10 mg per hour continuous infusion, or B. Ibutilide 1 mg IV over 10 minutes, or C. Digoxin 0.5 mg IV loading dose, or would it be D. Immediate direct current cardioversion, abbreviated as DCC? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Diltiazem 0.25 mg per kilogram IV loading dose, followed by a 10 mg per hour continuous infusion. Immediate DCC is not necessary or indicated because the patient is not hemodynamically unstable. That makes answer D incorrect. Digoxin is not a preferred drug for acute termination of SVT because of its slow onset of action and relative lack of efficacy. That makes answer C incorrect. Ibutilide, though effective for terminating atrial fibrillation and SVT with pre-excitation, is not a preferred drug for SVT without pre-excitation. That makes answer B incorrect. For patients with SVT with no evidence of pre-excitation, preferred drugs for those who do not respond to vagal maneuvers and adenosine are intravenous beta blockers or non-dihydropyridine calcium channel blockers. That makes answer A correct. Please progress to the next question. And the next question reads, MCV, in the above case responds to the treatment you selected, and she is now in sinus rhythm. After consultation with her cardiology team, MCV has decided not to have a catheter ablation done and prefers to take oral drug therapy to reduce the likelihood of recurrence of her arrhythmia. So my question to you is, which of the following would be the most appropriate therapy at this time? Would it be A. Sotalol 80 mg orally twice daily, or B. Propafenone 150 mg orally thrice daily, or C. Metoprolol tartrate 50 mg orally twice daily, or would it be D. Digoxin 0.25 mg orally once daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Metoprolol tartrate 50 mg orally twice daily. Digoxin is guideline recommended for patients with SVT caused by atrioventricular node reentrant tachycardia, abbreviated as AVNRT, and heart failure with reduced ejection fraction who require long-term therapy to prevent arrhythmia recurrences. However, digoxin is not a preferred drug class 2B for patients with SVT caused by AVNRT who have normal left ventricular function. That makes answer D incorrect. Oral propafenone is considered a second-line drug class 2A for patients with SVT caused by AVNRT who do not have structural heart disease, but it is not a preferred drug. That makes answer B incorrect. Oral sotalol is not preferred for patients with SVT caused by AVNRT if patients do not have structural heart disease because of its adverse effect profile. There is at risk of QT interval prolongation and torsid de Poor and because safer alternatives are available class 2B. That makes answer A incorrect. For patients with SVT caused by AVNRT who do not have structural heart disease, the drugs of choice are oral beta blockers or non-dihydropyridine calcium channel blockers class 1. That makes answer C correct. Please proceed to the next question. And the next question reads, SJB, a 79-year-old male patient was admitted to the cardiac ICU today due to an acute myocardial infarction. His echocardiogram reveals an left ventricular ejection fraction of 50%. He has a past medical history significant for hypertension and dyslipidemia. During SJB's admission to the cardiac ICU, he complains of dizziness and palpitations. His pertinent vitals include a blood pressure of 105 systolic and 70 diastolic. SJB's ECG reveals ventricular tachycardia (VT) at a rate of 135 beats per minute for over 30 seconds and does not terminate on its own. So my question to you is, which of the following would be the most appropriate treatment for SJB now? Would it be A. IV procainamide 25 mg per minute continuous infusion up to 17 mg per kilogram loading dose, followed by a continuous infusion of 3 mg per minute, or B. IV lidocaine 1.5 mg per kilogram loading dose, followed by a continuous infusion of 3 mg per minute, or C. IV amiodarone 150 mg over 10 minutes, followed by a continuous infusion of 1 mg per minute, or is it D. Immediate direct current cardioversion, abbreviated as DCC? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. IV procainamide 25 mg per minute continuous infusion up to 17 mg per kilogram loading dose, followed by a continuous infusion of 3 mg per minute. Immediate DCC is not indicated or necessary because the patient is not hemodynamically unstable. That makes answer D incorrect. Intravenous amiodarone is guideline recommended, but with a lower class of recommendation 2B than procainamide 2A. That makes answer C incorrect. Intravenous lidocaine is no longer recommended as a primary drug for terminating VT because data analyses show that it is less effective than amiodarone or procainamide. That makes answer B incorrect. Intravenous procainamide has a higher class of recommendation 2A than either amiodarone or sotalol, which both are class 2B recommendations. That makes answer A correct. And the next question reads, which of the medications listed below is most associated with increased cardiovascular CV risk? Is it A. bromocriptine, or B. haloperidol, or C. cyclosporine, or is it D. citalopram? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. cyclosporine. Cardiovascular risk is increased by medications that alter risk factors known to contribute to CV disease, e.g., hypertension, diabetes, hyperlipidemia, and obesity. The only agent associated with increased CV risk is cyclosporine because of endothelial dysfunction, hypertension, left ventricular dysfunction, and hyperlipidemia. That makes answer C correct. Both citalopram, dose-dependent, and haloperidol have a known risk of drug-induced torsid de Puer. That makes answers D and B incorrect. Bromocriptine can cause valvular disease. That makes answer A incorrect. Please progress to the next question. And the next question reads, PPU, a 24-year-old male patient is rushed to your accident and emergency department obtunded after a suicide attempt. PPU was found on the bathroom floor with an open bottle of digoxin 0.125 mg tablets, prescribed for his grandfather. The fill date on the bottle was 48 hours ago for a 30-day supply. A total of 8 tablets were found scattered on the floor. His grandfather confirms that he has swallowed only 2 tablets from the bottle. PPU's ECG reveals first-degree heart block, with a heart rate of 32 beats per minute. All his labs are within normal limits except for a digoxin plasma concentration of 5.2 nanograms per milliliter. In the accident and emergency department, PPU receives a total of 3 mg of atropine and temporary pacemaker insertion. The cardiology team asks your recommendation for digoxin-specific antibody fragment dosing, considering PPU's high digoxin plasma concentration and degree of bradycardia. So my question to you is, which of the following would be the most appropriate number of vials rounded to the nearest vial size to administer to PPU? Would it be A. 6, or B. 5, or C. 4, or would it be D. 3? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. 4. 2 formulas can be used to determine the number of vials of digoxin-specific antibody fragment to administer in the setting of severe bradycardia from digoxin toxicity. The first formula, total mg of digoxin ingested multiplied by 0.8, divided by 0.5, is used for acute toxicity, as described in this case. The second formula, digoxin concentration multiplied by patient weight, divided by 100, is appropriate for chronic toxicity. Given that digoxin was ingested for a suicide attempt, the acute ingestion formula should be used for this case. The total milligrams of digoxin ingested is needed to complete the equation. The patient should be assumed to have ingested 20 tablets, given that 30 tablets were originally in the bottle, 8 tablets were found on the floor, and his grandmother took 2 tablets. Using the acute toxicity formula, 2.5 multiplied by 0.8, divided by 0.5, the correct number of vials would be 4. That makes answer C correct. Incorrectly using the chronic toxicity formula in this case would result in 5 vials. That makes answer B incorrect. 3 vials are not enough in this case. That makes answer D incorrect, and 6 vials would result in 2 additional vials given unnecessarily. That makes answer A incorrect. Given the high cost of digoxin-specific antibody fragment, these formulas should be used to determine the correct number of vials to administer. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 196.